and the questions can be directed to any of us. Are there any questions? Go ahead.
So I have a two-part question. Patients who come in with triggered AFib event, like secondary to pneumonia or thyrotoxicosis, it lasts greater than 48 hours, but they have an elevated chance to vasco. Is there any merit to doing lifelong anticoagulation in these patients with a triggered event? And the second...
Okay, so the patient had something like that, some secondary cause.
Correct.
That's tough.
When you answer the question, would you mind
Yeah.
talking into the mic so it gets on the recording?
So the question was, if a person has atrial fibrillation probably resulting from a secondary condition like thyrotoxicosis or maybe alcohol or something else, should that patient get on a lifelong anticoagulation? I think if it lasts for a very short time, under 48 hours, you could make an argument that those patients could get away without anticoagulation. If it lasts for a longer time, you could make an argument that that's a little unusual and probably there's something about their heart that allows them to stay that way. If you, I think there's not really that much data that says we followed patients with secondary AFib off anticoagulation for 10, 15 years, and their stroke rates is the same as as someone who didn't have AFib. That data doesn't exist. That's what would really be needed to answer the question. The best strategy for that patient is if they have a low CHA2DS2-VASc score, you give them anticoagulation for maybe a month after they convert, or after you shock them or whatever. And then at that point, you follow them. And if they have any AFib, if they were symptomatic, you can wait for them to have symptoms. And if they do, then you know to get them on anticoagulation. If they never had symptoms from the AFib, you can't trust symptoms. That might be a patient where you periodically give them a vent monitor or Holter monitor or better, a loop recorder. You follow them so that if they develop a higher CHA2DS2-VASc score, 5 years later they get diagnosed with diabetes and high blood pressure, you may alter therapy. You kind of hedge the bets there. There's not really a one quick, simple answer for them.
Any more questions?
Given the high, I think at 3 to 5 years, the recurrence of atrial fibrillation post-ablation is pretty high. So, I mean, some of the data you presented regarding improvement in symptoms post-ablation, I've just noticed that it's up to 9 months or 1 year, based on one of the study I remember.
Now, there are some studies that have looked for up to 2 or 3 years, but no study has looked at symptomatic improvements or things like that for much longer than that. And you're right. There probably is a real recurrence rate that accrues with time. You know, one of the big questions is really what's the right endpoint to decide if this is worthwhile. If you ask yourself, if a patient had 10 seconds of AFib, you call the ablation procedure a failure, you know, the success rate for AFib ablation will go down, for sure. You know, especially if you look 10, 15 years in the future, you're going to have a 1% success rate. But if you ask yourself a more practical question, do the patients have improved symptoms? That really is clear. I mean, it's clear just from talking to the patients afterwards who've had the ablations over a long period of time. But it's clear to the people who do the procedure. To make it clear to cardiologists and internists, I think we're going to want something like the Cabana trial, which is following these patients over a long period of time and following a large number of patients over a long period of time. That gives us that data. Wilson, do you want to answer this?
One other thing I'd like to add with what Amish was saying is that if you think about coronary artery disease in the 70s and 80s, and you would stent a lesion or you'd balloon a lesion, and the interventionalist would come out and say, wow, we got it. We took care of business. And if you thought you were done, well, you fast forward 30 years and we're saying, wait a second, what about the statin? What about the coronary artery disease happening in other locations as well? I think AFib, like Dr. DeBakey had said, we're at the tip of the iceberg. This is a chronic inflammatory neuropathic condition. I like to say it's the zombie apocalypse of the left atrium, right? You have patient zero, this ectopic cell, or whether it's a neurogenic source that's causing irritation, that's causing inflammation, and just like The Walking Dead, you want to contain the zombies, ablation can at least try to control a little bit of the territory. But if they're breaking out and if the same diabetes, obesity, sleep apnea, the same inflammatory markers are working in AFib, if you don't treat those, there's probably going to be either a recurrence or some progression of scar tissue. So I think if we think about AFib in that direction, they still need to work on their snoring. They got to work on their obesity. That's probably just as important. And 20 to 30 years from now, we won't say, aha, AFib ablation, there, I stented the lesion. No, it's going to be what's the overall milieu that we're controlling, if that helps answer it.
You're not done with the patient after the ablation, though. Even if they feel great, you have to treat them.
What are the current recommendations for left atrial appendage occlusion for patients with atrial fibrillation undergoing, say, like a bypass, and there's no contraindication to anticoagulation? So not someone that would definitely merit having a Watchman outright, but they're undergoing another procedure.
So hold on, they're getting a surgery. They're getting
Yes.
bypass surgery.
Yes.
That's a really good question. There is no guideline for surgical left atrial appendage closure. There's no outcomes data. The largest trials for the AtriClip, for example, are single center studies involving 30 patients, followed for a month or so. The original data for surgical left atrial appendage closure, though, came from Dr. Cox of the Cox-Maze surgery in St. Louis. And there, when they cut out the appendage, they had an incredible stroke risk reduction of 90%, and that motivated all this. Practically speaking, so lacking hard guidelines, what happens everywhere is if the surgeon feels comfortable doing an AtriClip and doesn't feel it's going to add to his time, he'll do it. And if he doesn't really feel comfortable doing it, and he has a lot of cases, after this, he's not going to do it. So as referring physicians, you have some say-so over that. If you tell him, hey, I need to do this. If it's a young person, and lifelong anticoagulation is not without risks. It absolutely carries risks. As we saw in some of those slides, even with the NOACs, there's hemorrhagic risk with those patients. It makes sense to consider doing that, to asking the surgeon to do it if it's something he's comfortable with or she's comfortable with. If you are dealing with a person who probably has other good reasons to be on anticoagulation, a lot of these patients, probably have other atheroembolic risk than the thrombus risk in the appendage. I would probably make a lower recommendation. If it's a high CHADVAS score, I think it makes sense also. It adds about, to a surgeon who does a lot of these, the AtriClip adds maybe 7, 8, 9 minutes to the surgery, and they can do it off pump, and it does require them to kind of pull the heart forward this way, which temporarily reduces cardiac output, and the anesthesiologists don't like it and all that. But if they're doing an open thoracotomy, it's not a big deal. Go ahead, Lucy.
The olden days, when they were making the incisions as opposed to using this, there was a higher risk of could you get hematoma, could you get pericardial tamponade. With the newer devices, it's much safer. There are some ongoing studies that are saying there's a lot of muscle bulk that's in that left atrial appendage, and could that also be a nidus for AFib? And so people who are looking to occlude it, not with just a Watchman, but basically cinch it off, denervate, decrease the blood supply to the tissue, can that help decrease the burden? There are some papers that have looked at, does it decrease the atrial kick, but not many people know whether or not that has any clinical relevance. So those are the competing theories.
So just to add a little bit more to your question and what Dave and Nan said, people who are not contraindication for anticoagulation that require closure devices. So triple therapy patients, right? It's a hot topic right now on closure devices because the risk of bleeding is high. It's not that there is contraindicated, but there's a substantial risk of bleeding than any other person. We have people doing for aspirin Plavix for maybe some life-term condition. I wouldn't recommend it in somebody who has short-term triple therapy, but if you're expecting somebody to be on aspirin Plavix for long-term, and then now you're going to add a real blood thinner for 10, 15 years, he's going to bleed. He's very likely going to bleed. So that's another one you could consider. It's not that we recommend it, but it could be considered as an alternative to do a closure devices, okay?
All right. I'd like to give a couple housekeeping